our presentation today is titled Creative Treatment Strategies for Rehabilitation Throughout the Aging Process in Chronic Brain Injury. So just so you can see who we are, as mentioned, I am Jenna Tucker. I am a clinical assistant professor at Kean University. I am a board certified neurological clinical specialist and a certified brain injury specialist. And we also have our other speaker today, Alana Beicher, who is an occupational therapist and adjunct professor at Kean University in their OT department. And Alana and I have worked together for about 11 years now, working with the brain injury population. And just to make note, neither of us has any conflicts of interest to disclose. Before we get into our presentation, we would like to give some special thanks to 4 students who helped with the collection of all the information for this presentation and compiling it together. So thank you very much to Gigi, Janal, Hannah, and Usha. We are very appreciative of all of your efforts in this process. Our objectives today, we're gonna start, oh, sorry, somehow the numbers got messed up. That should say 1, 2, 3, 4. Our objectives today are to summarize information from some current research that talks about aging in clients with a history of brain injury. And just to clarify, this is not brain injury in an older population. These are people who have had a brain injury in their lifetime and are now dealing with the effects of the aging process. We're going to identify some of the common challenges that we face as therapists, particularly geared towards PT and OT, but other disciplines as well, when treating long-term brain injury. We will describe how we implement some of these creative strategies that we've used and developed over the years to really enhance the treatment for this population and maximize their outcomes. We will also, at the conclusion, go through a case study of a client that Alana and I treated collaboratively and how he really benefited from some of the strategies that we're going to talk about today. So we're going to set the foundation a little bit and talk about the aging process in general. So when we talk about quote unquote normal brain aging, if you look at some of the research that's out there, particularly this study that we reference here by Moretti in 2012, it really talked about how brain volume begins to decrease after age 50. And this starts with changes in the gray matter. So you will have and particularly in the frontal cortex, gray matter in the frontal cortex. You'll see some early neuronal loss. You'll see a decrease in synaptic density, which is a result of increased synaptic pruning and reduced plasticity of your synaptic connections. There's also some aging microglia, which threatens neuronal survival. And this is due to the fact that they're at increased risk of becoming either dystrophic or producing substances that can attack neurons. After you see gray matter changes, white matter changes usually come a little bit later on, and they start around age 70 on average. And they can lead to this reduced nerve conduction velocity and loss of some nerve fibers, which really results in that cognitive decline that's associated with the normal aging process. So in 2016, Pinto and colleagues, who we reference here, proposed this concept that when looking at changes related to brain function, it can be broken down into what we call brain reserve and cognitive reserve. So we'll first briefly discuss brain reserve, which is what they reference as the hardware of your brain. So this is based on the size of your brain, your neuronal count, and your synaptic density. So damage to your brain reserve is essentially damage to the structures of your brain. So an example would be a traumatic brain injury. Multiple studies have demonstrated that neurodegenerative changes within your brain can produce a variation in clinical presentation, and we know this from seeing patients, as well as severity of cognitive aging. So the extent and timing of cognitive decline that we see during normal aging is very variable, right? And despite these degenerative changes being similar in their nature or the extent. And this concept led to the emergence of what we now call, excuse me, cognitive reserve. which is potentially responsible for this variability in the presentations that we see. So cognitive reserve focuses on the adaptability and flexibility of your brain, which allows certain people to compensate better than others in the circumstance of either age-related pathology or damage to your brain reserve, right? And again, we see this in patients. Some people completely floor us and recover in ways that we consider miraculous, and other people struggle a little bit in their recovery. And so this is trying to give us some understanding of why we see those changes despite a similar brain injury between two people. Okay, so cognitive reserve really represents an active model, and that's how your brain copes with any damage to the brain reserve. So what your brain does is either uses some pre-existing cognitive processes to increase the efficiency and capacity of your neural pathways, or it can be by compensating to recruit new pathways that are not usually used to perform a specific tasks. Okay, so what we call neuroplasticity. Therefore, somebody who has a higher cognitive reserve is often able to handle a larger lesion or more damage before clinical symptoms appear, despite two people having a similar amount of damage. Okay? And the ways that this study and other studies as well talk about building your cognitive reserve is having a higher education, having an interesting and engaging occupation, healthy lifestyle, and then factors that reduce your cognitive reserve are being sedentary, poor nutrition, a lack of education, social isolation, etc. And so all of these things that contribute to cognitive reserve establish whatever cognitive reserve you have at the time of injury. However, after injury, using these factors that promote cognitive reserve can continue to build it back up. So as therapists, we want to help clients build up their cognitive reserve to really maintain as much functional abilities as they can. All right, so now we're going to use that to talk a little bit about aging after a brain injury. And again, Dr. Corrigan did a nice job kind of laying that foundation for us, talking about what it looks like for chronic brain injury. So here we're going to talk a little bit about the disability and complications that follow brain injury, and they can fall into usually one of these four domains. So either physical, cognitive, emotional, or psychosocial. And to note, although physical deficits can often improve with time, with rehab, they're often eventually counteracted by the physical effects of natural aging. And in addition, cognitive and psychosocial, as well as emotional impairments, can actually worsen years after injury, especially without proper rehab or treatment. So when we look at the physical domain, we have patients that already have these physical symptoms, maybe fatigue, spasticity, pain, things like that. And then in addition, as they age, although maybe we're counteracting some of those symptoms with rehab, aging will set in, and they may have age-related joint changes, such as arthritis, changes in their bone density, increased risk of infection, etc. And so it just kind of compounds those physical complications. And the same concept goes for the other three domains as well. And we're going to get into some of those a little bit more in the next few slides. So here we're going to talk about, if you recall back, I explained the difference between brain reserve and cognitive reserve. So this side is going to focus a little bit on the effects on brain reserve, or the brain structures and their function. So after a brain injury, you can have interruptions to your neural networks, which can affect either short and or long-term fibers and or tracts. And these can all have a negative impact on your neural connectivity, right? In addition, you can have axonal damage, and in more severe cases, that can lead to progressive deterioration, such as Wallerian degeneration. You may have diffuse axonal injury, which is can disrupt your vital pathways And that can lead to some really widespread cognitive deficits, which in my experience are amongst the most challenging to treat as a therapist. You can have reduction in your global brain volume. And there is research out there that talks about the connection between the longer the duration of coma, the greater reduction in brain volume that is seen, okay? So in conclusion, from this slide, brain injury can have a significant impact on your brain reserve in a lot of different ways. And we know that every brain injury is different, right? Everybody's brain itself is different, every injury is different. And these are just some of the potential things, the effects that can happen.
Okay, so now we're going to explore a little bit more of the factors that can contribute directly or more directly to cognitive decline in an aging individual with a brain injury. So we know that compensatory processes are used to maintain brain function as one ages. Imaging shows that there's more brain activation in older adults compared to younger adults to complete the same task. So this reveals, as we can see, that the brain is using more effort to complete the same task, which can impact the efficiency of how the brain is working. If we add that to someone whose brain function may have already been impacted by an injury, even further compensatory strategies may be necessary, which again impact the efficiency and effectiveness of the brain function. Additionally, functional MRIs also show changes in network connections in normal aging, something that again can be exacerbated by a prior injury. Additionally, primary pathways that were established during development may have become damaged and replaced with redundant pathways after an injury. These new pathways are not as energetic and function differently than the original pathways did, which again can cause more brain vulnerability to aging. Also, the hippocampus, which we know has to do a lot with memory and cognitive processing, is very vulnerable to aging and is often affected in patients with a brain injury. So again, if this area was already impacted by an injury, it's even more susceptible to further decline with the onset of what may be normal aging on top of the injury. So this is a nice graphic out of a Moretti study in 2012. It depicts for us the hypothetical changes in neural networks and in normal aging and after brain injury. And so as Jenna spoke about earlier, and per the authors, and I quote, initial brain injuries resulting from traumatic brain injury combined with the expected pathological changes of normal aging can result in an increased risk of exacerbated cognitive decline. And so that leads us really to what Jenna was speaking about earlier. So now if we look at the top figures, they depict the aging brain of an individual without a brain injury. As you can see in the first graphic on the top left, there are numerous connections, and this depicts an overall healthy neural network, right? We can see everything is nicely connected to each other. There's no large gaps. The figure to its right depicts how some networks and connections may be lost with normal aging. So, however, you can see that for the most part, the pathways are still generally intact and connect one area to another with very minimal gaps. So now, if we look at the bottom two graphics, the one on the lower left depicts the neural networks after a brain injury. So as you can see, after an injury, several nodes or small-scale neuronal networks within a brain region are missing. So we could imagine how this can affect someone's functioning. If we then look at the final figure on the lower right, this depicts an individual with a brain injury and aging on top of it. You can see that there is a significant loss of nodes in this image and reflects limited connection between various areas. So you can imagine how this could potentially impact functioning, specifically cognitive in this diagram, but you can also imagine how it could affect physical or other functions for us. So if you compare this figure on the bottom right to the one immediately above it, you can really see that while the healthy network was minimally impacted by the loss of connections associated just purely with normal aging, the network damaged by traumatic brain injury and aging can be much more severely impaired during this normal aging process. So we'll continue to talk a bit more about a few age-related changes and if they can be exacerbated by a prior injury. So first, there can be vascular aging, which results in changes in our blood-brain barriers. There can also be sleep alterations. And so there's an increased likelihood of sleep apnea and circadian disturbances with age. 66.7% of individuals with chronic TBI also have a sleep disorder. I'm sure that we can all relate how critical sleep is to effective, healthy brain function and for all of us to be functioning at our utmost potential. So coupling the two, an underlying sleep disorder with the increased likelihood of sleep alterations as we age, this can really impact the function of someone with a brain injury. There's also age-related hormonal changes, and these include things like a decrease in sex hormones, a decrease in thyroid and growth hormones, all of which can negatively impact our cognitive function. There is also naturally occurring atrophy of cerebral tissue with age, like Jenna referenced earlier. Traumatic brain injury can cause a brain volume and myelin density reductions, so this naturally occurring atrophy with age can lead to even more rapid decline and earlier onset of symptoms or of age-related symptoms. There's also age-related changes in immune regulation, which can include inflammation, which contributes to tissue loss and poor brain connectivity, and as well as microglia are vulnerable to the effects of aging. So really we can see how so much of this can be normally related to aging, but can be just exacerbated in somebody with an underlying injury earlier in life. Okay, so this is a really nice graphic that nicely puts together so much of what we've already been talking about and comes out of a Griesbach article from 2018. So on the left, you'll see listed the chronic effects of a TBI, many of which we've already discussed, like sleep alterations and white matter atrophy. On the right, you'll see age-related changes that are associated with cognitive decline. Again, we've discussed many of these, such as vascular aging, age-related hormonal changes, and decrease in cerebral tissue already. So now if you look at the top and bottom arrows, you'll see the protective factors and exacerbating factors for decline. So these should again mostly look familiar as Jenna spoke about them earlier, but just to give a few examples, some protective factors can include things like higher education, good nutrition, and rehabilitation, while exacerbating factors can include things like a seizure history and psychiatric disturbances. And so the interplay of all these components results in the increased potential for cognitive decline and the increase in pathological characteristics associated with neurodegenerative diseases. It is important to note here that the protective factors that we've been referencing can help to delay or mitigate some of these other factors, and rehabilitation or the services that we all provide can be a key protective factor to help delay this or minimize the onset of these other exacerbating factors and aging itself. So next we'll talk a little bit about predicting the long-term effects of brain injuries. And of course, no two injuries are the same, no two brains are the same, and prognosis cannot always be predicted accurately. However, we do know some generalities, and Dr. Corrigan alluded to a lot of this earlier. So life expectancy, we know the level of mobility is an important predictor. We know that life expectancy is limited for someone with limited mobility is typically about 10 to 15 years after injury. There are factors that can influence the overall prognosis, and these should probably look familiar to you now, as the supporting factors include some of the same things we've been talking about for increased cognitive reserve, such as higher education, physical exercise, intellectual ability, and all those factors. Inhibitory factors in prognosis can include a pre-existing psychiatric or emotional disturbances. In terms of treatment, things that can help predict long-term effects can include strategies that specifically address changes in the neuroendocrine and immune systems, and we just heard about how aging can also impact those systems, as well as the role of multidisciplinary rehab to improve functional outcomes and life expectancy. And again, that's the service that we all can provide. So now that we've discussed the overall background of aging with a brain injury specifically, now we're going to talk about some of the treatment challenges that we have found and encountered in treating this specific population. So there's many external challenges, as I'm sure many of you can relate to. So first on the list, we see reimbursement. We all are familiar with ever-changing insurance coverage, reimbursement rates, therapy caps for skilled services. Many of us are fighting day to day to get our clients the services we feel they so desperately need. The next two external factors of the client are their living situation and caregiver support, and I'll discuss them sort of together. For some of our individuals, maybe they were injured in their 20s and have been living with their families for many years since. Let's say the individual's now in their 60s, their caregiver is now in their 80s. And so unfortunately, there may become a time where the caregiver can no longer provide the needs, especially as the client themselves are aging, or unfortunately, they may pass away. And so this may yield to a change in their living situation, whether it's the move from this home they've lived in for many years to an assisted living, a residential program, or even a long-term care facility. And the caregiver can change. Again, from somebody who could have been carrying them for 10, 20, 30, 40, 50 years, suddenly now they have a new caregiver that maybe does things differently. And so you could imagine that for someone who has maybe been in sort of this same routine environment and with the same caregivers, for everything to suddenly change can really uproot their function and their cognition and so much of their day-to-day. As we talk about these external factors, let's just mention the cost associated with aging and brain injury. And we won't spend a ton of time here, but just so you have some estimated numbers, you can see traumatic brain injury's annual cost across a few countries, ours being almost $80 billion. Those costs are comprised of acute medical care, rehabilitation, and loss in productivity. We can also categorize it by lifetime cost by severity. And again, this is listing only moderate to severe TBI, but again, you see the cost is in the millions per person. Additionally, there's additional costs associated with just aging. There's the cost to maintain lifestyle, right? Clients can't do the same things they did in the same ways they did it. They need to find new ways. And again, some of these coping and adaptive strategies that maybe they learned in their inpatient rehab when they were first injured just are not working anymore. And so there's costs that could be with home modifications or more equipment as we go on. Just a quick note, research did show us that post-traumatic amnesia duration was the single best predictor for each type of cost. So the longer post-traumatic amnesia, the higher the cost. And other things that help predict this included things like moderate to severe limb, facial, chest, or back injuries. And again, so that's just interesting to note about what went into determining some of these numbers. So we'll move on now from those external challenges that we've seen to the client-related factors or things within our client themselves that we face. And so as we've been talking about this whole presentation, there are those normal aging symptoms that can be exacerbated by having had a previous brain injury. Additionally, some of our clients encounter plateau of progress. And Dr. Corrigan, again, really spoke to this. Not only could it be a plateau, but it could be a decline. He gave us those statistics earlier. And a plateau of progress could be due to many things. It could be a progression of comorbidities. It could be the onset of these age-related complications we keep speaking of. And it could also be related to other changes in medical status. There can also be changes in motivation in the client themselves, right? We just spoke about all these things that could change. They could be having new medical issues. They could have lost their caregiver. So maybe they're frustrated because of this lack of progress, their change in their status, or in general to everything else going on. There could also be, Jenna and I have seen in our practice, some emotions relating to perceived or actual missed milestones. So we've had clients who've really struggled as they've seen their colleagues or friends go on to become grandparents or get married, or those kind of milestones that they feel like they're missing out on. And that's really impacted their function. Additionally, we have also seen some side effects of the long-term use of some medications. So now that we've spoken about all of this, why is this topic worth addressing? Why is this client population so important to us? And so for one, it's the role of the professional to promote quality of life despite any challenges we face. And this is embedded in most of our, if not all of our, professional core values and code of ethics. Additionally, there's a potential for cost reduction. We just saw how much it costs. So if we can help maintain function and preserve independence longer, some of that cost can be put off or mitigated. We can also try to reduce the burden of care on families or caregivers, especially as they too are aging. And we also want to maximize community participation, and of course, independence. So there's a lot of studies that go into how feelings of independence and community participation relate so highly to quality of life and overall life satisfaction. This is something we definitely want to focus on because, again, it's so key in someone's perception and quality of life. And as this population continues to grow, we just need to learn how to better manage and treat these clients now instead of later. Okay, so now that we've discussed the process of aging in adults and our treatment challenges and why we feel this is important to address, we'll move on to what we really want to discuss with you guys, the creative treatment strategies for adults aging with a brain injury that we have found have been helpful. So of course, as clinicians, we always want to utilize standard evidence-based treatment. So these are not necessarily to do instead of other things, but to do in addition. And based on some of the challenges we have identified earlier, especially in terms of the motivation, plateaus in progress, and changes in living situation, Jenna and I have found that integrating new treatment interventions for this population's plan of care was really beneficial. It is important for us to just briefly note that some of these may not be totally new and novel interventions you've never heard of, but they may be new to the clients at this stage of their life and in this stage of their rehab process. So there's some key things that we want to consider when we integrate these new and effective treatment strategies. Of course, we want it to be interdisciplinary. We want to look at the whole person and have an ongoing discussion of relevant goals, not just between disciplines, but between the client as well. And again, when I say disciplines, Jenna and I are PTs and OTs, but I'm speaking about all the disciplines. So speech, recreation therapist, cognitive therapist, neuropsychologist, any member of the team is vital here. We also want to be sure that we're incorporating our client's interests. As someone's aging, perhaps their interests have changed. So we need to explore that, but we also need to explore the fact that maybe their interests haven't changed, but due to some of these aging limitations, maybe we need to help them find new ways to engage in pre-existing interests and really think outside the box. So just to briefly mention, by introducing some of these novel treatment interventions, we also hope to help protect against cognitive decline. There is some research that has shown that introducing more new things as people age, and this is in healthy populations or those with injuries, has an improved benefit over engaging in the same familiar ones, even if they have a stimulating impact. And so by us helping our clients to engage in something new, we help to encourage this to increase or maintain their levels of cognitive reserve. And so ways we can do this include things like cognitive training exercises, new behavioral strategies, trying to minimize those confounding factors that are listed. And as I mentioned before, really promoting social interaction and community participation because they are so vital in quality of life. So these are the strategies we're going to spend time discussing now. So community reintegration activities, community involvement projects, canine-assisted therapy, group activities with a common goal, group fitness class, and the incorporation of music. So we'll first start with community reintegration activities. And so there's several goals and key components we have found necessary for a successful community reintegration program. And they include providing, as I spoke about earlier, an interdisciplinary treatment, facilitate client community-based goal achievement, so not just practice skills, but really do it in the community. We can want to integrate varied skills of all the disciplines. So again, not just practicing something like curb or ramp negotiation, but also practicing then following a shopping list and money management. This helps us also facilitate the progression and generalization of skills that we work so hard on in the clinic. And we also want to enhance the psychological well-being. And as I keep speaking about, social interaction and community participation are huge factors in this. So in our experience, Jenna and I ran a community outing group once a week with anywhere between about 4 to 6 clients. So it was a good-sized group, and we would go out for about a 2-hour period to various places in our community, such as local food stores or bookstores. We even did some social things like restaurants or going bowling. So anywhere in the community that either clients requested to go or we felt would be beneficial or out of a need. So perhaps this was the one time a week a client could get out and do some shopping. And so as we went to all of these different places, we were able to address this variety of skill sets. And again, in our case, we ran the group as a PT-OT team, but there's no reason that other disciplines couldn't integrate something similar to work on things more specific to them. The goal is that we address really overall skills and multiple things at once to help best improve community reintegration skills. So some of the things, and I won't go through all of this, but they could include things like topographical orientation. So things like wayfinding and using environmental cues that could be very visual based and memory based, but then also combining it with something like functional mobility. So while they're doing that, ambulate or negotiate a wheelchair over various surfaces, engage in dual tasks, navigate things like curbs, ramps, and doorways. We could address things like money management. So in this case, perhaps somebody had previously used a money management strategy that based on decline, maybe they couldn't use anymore. And so this gives us an ability to help them work on a new strategy we're teaching them in the clinic and apply it in real life. Other things may be vehicle safety. So perhaps they're getting in and out of vehicles differently than they were. And again, we could do things like social skills. So interacting with us as therapists, other members of the group, other patrons in a store, or staff employees. So maybe someone never had to reach out to employees for help before, and now they do. This is a great way for us to get them comfortable with that idea. And again, the key components are that this is multiple disciplines working together with real life skills in real life settings and getting our clients out in the community to help apply these new strategies and techniques that may be different from what they were used to using before. So another similar area is community involvement. And so in contrast to just getting out in the community, this is really about feeling like an active, contributing member of your community. It's a little similar to how someone who retires may pursue a volunteer opportunity or explore leisure interests to give back that they just previously didn't have time for. And so for our clients who may have worked before and no longer can, this is also a great way to help recapture feelings of productivity. So some of the examples that we've found and integrated into our practice are things like finding new and modified ways to become involved. So for example, we have had clients engage in a safety promotion. There was a construction done near our facility. There was an unsafe intersection for pedestrians and vehicles because it added more ways at an intersection that had previously really just been 2 directions, was now 4 directions. And so our clients were able to write letters to the mayor, advocate for safety, and in the end, their efforts paid off. The mayor came and thanked them for their efforts, and in fact, a 4-way stop sign was integrated. So this was just such a huge way for them to feel like active contributing members. Other activism and advocacy projects we've done are things like making dog toys for shelters, writing letters to service members, and all sorts of supply drives like food, school, and toy drives. Other things can be community-wide events like the annual Brain Injury Walk for Thought. And there's other retiree type roles such as volunteering at places like a VA hospital or reading to children at a local daycare or, finding some part-time work. Now, in all of these activities, there's different ways for each discipline to be involved. And so some of this may seem like it's more OT, speech, or cognitive based in terms of things like writing letters and doing fine motor tasks to create toys. And so depending on what the activity is, each discipline can integrate it. Physical therapy can definitely be involved, such as if we're making deliveries for some of our toy drives, they can be involved in that component. And so we've kind of just gotten really creative, and you can imagine how many skills go into each of these tasks. And so we can really continue to strive to make things interdisciplinary as best we can there. So next we'll discuss canine assisted therapy. So just to give a brief definition, animal-assisted therapy involves interaction between patients and a trained animal, along with its human handler, with the aim of facilitating patients' progress towards therapeutic goals. It's designed to facilitate progress or maintain functional skills, enhance motivation, and can also provide emotional support when indicated. So I have worked with a facility dog, and there was this training and certification process that we both had to go through in order to implement this. So this one definitely does take a little bit more prep and work behind the scenes. However, integrating canine assisted therapy does bring many benefits that are evidence-based. And so there are physical, cognitive, communication, and emotional support benefits. Some of these specifically have included increased concentration, improved social competence, motivation, and self-reported satisfaction. Some of the strategies that we've used can include a variety of things that can be upgraded or downgraded. Clients can play fetch or brush or pet the canine. The canine could be placed on an elevated surface on one side or the other to help someone with visual inattention look towards one side. They can also stand on dynamic surfaces while doing things. We can integrate speech and memory components by having to state single commands or having to state sequences of commands to the canine. Really, the possibilities are very, very wide and endless as we can get really creative. And so this was really a new way for some of our clients to help address their goals. And it allowed them to just sort of address their goals without actually thinking about it as therapy. They just felt like they were playing with the dog, which was really nice.
Okay, so now we're going to talk about group activities with a common goal. And Alana spoke about our community integration group, which is one example, but we also wanted to touch on the other possibilities that are out there. And Alana and I have worked as part of a large interdisciplinary team. And within that team, different groups of different combinations of therapists have established various groups, some of them listed here. And what we want to highlight is the most important thing is to find out what is relevant for your patient or client and what they're interested in. So maybe somebody has no interest in cooking and they don't have to because they have a family member that does it. Obviously, they're not the greatest fit for a cooking group. But maybe, as Alana spoke about, as they age, they want to get back to doing some cooking because that's something they liked to do when they were younger and they want to find a way to do it. So we had run 2 different cooking groups in our experience. One, and they were actually run at the same time. And one was I'll say a higher level cooking group where there were clients who were looking to really be able to do a good amount of their meal prep, either independently or with some supervision. And we worked on everything from following a recipe to being able to carry a pot across the kitchen, right? So OT related, PT related, etc. There was another group where they just wanted to learn to simply be able to make a sandwich for themselves. And it was a little bit of some fine motor and motor planning activities to work on compiling the components of a sandwich. So you can tailor it to fit the needs and the level of the clients that are within that group. And there are other options here. I won't go into all of them, but I encourage you to be creative. It really is an opportunity to work on interdisciplinary goals for that whole person approach that we talked about, while promoting socialization, which we know is so crucial for maintaining functional independence and quality of life. So one of my favorite things that I've done as a therapist was develop and run a group fitness class. And if my video worked on this delivery of virtual presentation, Beyonce would be telling you about how important it is to exercise. A lot more fun than I could. Unfortunately, that video is not working. So, however, what I want to talk about is this class that I had designed and ran, where it was a multimodal class. So it was about 45 minutes long, and the first 15 minutes was a combination of some cardio and strengthening exercises. To make note, it was a seated class, and the participants ranged anywhere from 5 to 20 participants were in a big circle. Okay, so I mentioned the first 15 minutes were some cardio and strengthening in the seated position. The second 15 minutes was some adaptive yoga. And the last 15 minutes was guided meditation. I will just make note that although as therapists, we are used to doing range of motion and strengthening and etc., adaptive yoga may be outside of the realm of some of our expertise. There are some wonderful continuing education classes out there on how to integrate adaptive yoga into your treatment as a therapist without having to be certified as a yoga instructor. So some of the benefits of these group fitness classes are, one, the general benefit of promoting long-term health and wellness, right? The same reason that anybody exercises. We want to maintain a healthy lifestyle. Cardiovascular effects, effects on our strength, things like that. But specifically putting people into these groups to have a fitness class, it creates a less demanding environment. And that I actually will say was direct feedback from a good handful of the participants in the class that I ran. They felt like for so many years when they were in either one-to-one or two-to-one treatment sessions with a therapist, they felt very much the focus of the therapist's attention. And sometimes that was intimidating or frustrating for them. And so to be in this group fitness class, they felt like it was a little more fun. They didn't feel so, that they were so focused on. And going off of that, there was a lot of peer-to-peer encouragement. They felt like looking around and seeing that other people were having a little bit of difficulty, but they were powering through it, really motivated them to just keep going and to not feel as frustrated. And it's, kind of goes along with the same reason that I'm sure many of you stuck in your houses now are a little frustrated that you can't get to the gym and you want to go out to go to a yoga class or maybe run a race where there are lots of people running for a good cause, right? That camaraderie, that encouragement, that motivation that we build from each other is really important. And so just to make note, I know we are in a very challenging time right now with the COVID-19 restrictions, but that's not to say we can't run group fitness classes virtually. I know plenty of wonderful therapists who have started doing this and have had some really great results. So in addition to the general results we normally would see with exercise, there's also cognitive benefits of being in a group fitness class. So being able to follow directions that are not specifically directed towards one person, right? General directions that are being delivered to an entire group. Information processing in a group setting, or paying attention when there are other people around. It helps promote that self-awareness aspect of things. Some other additional benefits, physical benefits are listed here. So improving coordination, motor planning, postural re-education that are seen amongst this population. So it can be really helpful, like I said, to participate in a group setting. So the last one we're going to talk about is not a treatment strategy in and of itself, but the using music really as an adjunct for your therapy. And although research is a little bit inconclusive on the benefits of music, there is some research out there that is starting to show that there are some potential benefits. As clinicians, we have absolutely seen a lot of benefits, and I'm sure many of you have as well. One of the biggest things is increased motivation and attention and participation. And we already talked about how loss of motivation with aging can really become problematic. And so we've used a variety of strategies, you can see some listed here, on how we can help improve motivation. So maybe a client is like, I'm not feeling therapy today. I just don't want to participate. Can we only do 5 minutes? And maybe we say, okay, how about you pick 3 of your favorite songs? We'll play them in the background. And then once those songs are over, that'll be the end of your session today. And I found that really works. And then actually a lot of clients wind up saying, maybe I'll stay a little bit longer. And it's, you know, if you guys are ever around your house doing some chores, how many of us put music on in the background, right? It helps us kind of stay motivated, stay distracted from what we're actually having to do. It's wonderful in collaboration for goal setting. One of my favorite stories to tell was a client who came to me with some pretty significant balance deficits after brain injury. And her goal was to dance at her daughter's wedding. That's really all she wanted to do. And so we used it. We incorporated music in a variety of ways into her treatment sessions. We did some choreographed dances, like practicing the Macarena or the YMCA. We worked on some game-based music, use of music, so playing like freeze dance, so starting and stopping, which really helped with some motor control and motor planning for her, and then carried over very well for her balance. Just a note, the woman did wind up dancing at her daughter's wedding in the pair of shoes she was really hoping to be able to do it in. She was very, very excited. And then it turned out she actually afterwards came back to tell me that she had rejoined taking some community dance classes that she had stopped doing because she was embarrassed about her balance impairments. And it really goes to show that something as simple as adding music to your balance activities can go a long way. It can all, like I said, there's a variety of different strategies and they can be tailored to the goals of the client, the likes or dislikes of the client, and the therapist's, the disciplines that are working with these people. I do encourage you to be as creative as possible. I forgot to mention this in the beginning. There are music therapists, and I'm not trying to say that we should be doing their job. I think they're a wonderful group of clinicians to work with and collaborate with to help develop some more strategies that may be more complex than these. But just know that it is an option out there to really help increase the motivation and really maximize the benefits of your treatment sessions. The last thing we're going to do is we're going to talk about a case study. This is a client who Alana and I both worked with for about 6 years. He is a 46-year-old male who had a right frontal craniotomy secondary to multiple calcified periventricular and frontal and parietal lobe lesions at the age of 18. So this was an acquired brain injury. His initial symptoms, it was very interesting. The only symptom he had was a 1-month history of psychotic behavior. And in speaking to him, he'll tell you how incredibly frustrated he was, and his family was, because the entire first month, the month of these symptoms, a lot of doctors and emergency visits, etc., were writing him off as just being an 18-year-old who was probably using illicit drugs. And he was very frustrated by that. But eventually, they did do some imaging and he received his diagnosis. Unfortunately, during his surgery, he did wind up with a postoperative, or after surgery, he wound up with a postoperative CVA. So in addition to the original impairment seen, he also had some resultant right hemiplegia. So a little timeline of his recovery process. Back in 1991, at the age of 18, he was in acute care for about 3 weeks. He went to inpatient rehab for 6 weeks, and he was then discharged home with his mother, who became his caretaker. In 1998, he was admitted to an outpatient brain injury rehab day program where he participated in PT, OT, speech, neuropsychology, etc. And then in 2000, due to some changes at home, he transitioned to residential services, where he was now receiving some supervision in a group home, and still attending the outpatient day program as well for therapy services. we're going to talk about this in the next few slides, but between 2000 and 2016, he really maintained his pretty high level of functional abilities during that time. And in 2016, the therapy team started to notice some changes. And we did a lot of investigating alongside the medical team. And it was concluded that a lot of these were related to the onset of aging. So his initial evaluation, which was not done by Alana or I, just to make note, we did go through his medical records and some interviewing with him. But it was done back in 1998 upon admission. And you'll see here, I'm not going to read it all to you, but he was pretty independent, pretty high functioning. He was modified independent with most functional mobility and cognitive activities, really needing supervision for some more complex standing activities or higher level executive function, things like that. He did have, the things to note for functional limitations were some moderate postural abnormalities, and some gait and some hypertonicity and spasticity, both of which resulted in some gait deviations, but he compensated well. He also had some limited social skills, safety awareness, things like that, but again, pretty high level of function. So between 1998 and 2016, he did receive interdisciplinary therapy, as listed here, you'll see. And these are some of the things that each therapy session worked on. He also was working part-time from about 1995 to 2017. The majority of that work was as a dietary aide in a local hospital, which he loved. If you ever asked him about his work, that was his true passion. He loved feeling like he was a part of a team and that he was contributing to the recovery of others. And he really, really felt very fulfilled by this job and his position there. So a lot of his therapy sessions focused on kind of, I don't want to say maintaining his functional ability, but really kind of staving off the decline from the onset of from other symptoms, and some mild improvements along the way here or there. But you know, it was some days are better, some months were better, some were worse, kind of flowed back and forth. But really overall, his baseline was pretty consistent all the way up until 2016. So then in early 2016, we started to notice some changes. Ironically, later on in the year, he did have a grand mal seizure, but follow-up medical appointments, as well as some imaging and testing, etc., revealed no residual changes or deficits as a result of the seizure, and they really had no kind of indication as to why it occurred either. He had no history of seizures prior. In 2016, due to some changes we're going to talk about in a little while, he did wind up having an AFO prescribed. And in 2018, as a result of some of the changes we saw over those previous 2 years, he wound up falling down a flight of stairs. And the only injury was a mild concussion. And we'll talk about some of the results from that as well. However, in 2017 and 2018, he underwent, like I said, many medical studies, imaging, consultations, etc., and really nothing significant was found medically. No new tumors, no changes in blood work, nothing that we really that stood out to anybody. Some medication changes to note. We did do the medical team did a trial of baclofen, but there really was no discernible improvement. He was switched from Zoloft to Effexor. Again, no big changes. So there were some things that were shifted around, but nothing really that kind of stood out. One of the things that we did note was a pretty big change in his psychiatric state. He had, over the course of 2016 to 2018, these increases in manic episodes. He really started to have these very intense periods of mania. He didn't go down into quite as big of a depression between the episodes, They were trying to manage it with medication, but just something to note there. After that fall, the concussion that resulted in a concussion in 2018, we did see a very big increase in depressive symptoms, which his neuropsychologist noted was likely due to the resultant loss of some independence. So because he had fallen, we as a staff were providing more supervision, and we limited his independent time out in the community. And we think that was really the result of that onset of depression. So over that course of time from 2016 to 2018, these are the changes we had seen. Some of these, actually majority of these, started before the seizure, before the fall. So nothing was an abrupt onset. A lot of it was very, very gradual. He had some cognitive decline, so a decrease in his processing speed and information processing. We definitely saw a change in his memory. Some physical changes. His posture, which already wasn't so great to start with, really took a turn for the worse. And a lot of that we think was due to some increase in tone. One of the most peculiar physical changes we noted was a very significant weight loss. And again, medical workup really gave us no explanation for it. He had no changes to his eating habits or his exercise habits that we really thought would attribute to such a significant weight loss. He had a pretty big increase in behavioral issues. He was having a lot of frustration and these episodes of verbal outbursts and aggression, which are very uncharacteristic for him. As a result of all these changes, his mobility status changed, and he was, like I said, he now required supervision when negotiating stairs. He was requiring supervision for community mobility and for some other cognitive tasks such as medical management or meal prep. And this frustrated him, and I think it kind of snowballed some of those behavioral issues. As a result of all of those things listed on the left, he also wound up losing his job, and I think that was in late 2018, and that really also contributed to that depression we talked about. He was prescribed reading glasses, which was confirmed as a result of normal aging. So as a result of this, we did make some changes to his treatment plan, his goals, things like that. And one of the biggest things to note was we did increase PT to 3 times a week, where he had previously been receiving it 1 to 2 times. So he is a very unique client in that although we saw these changes, we had built a pretty good relationship, him and myself, as well as him and Alana. And after some, discussions, he really started to see the benefit of maybe trying some new things. It took quite some time to convince him. He was a little bit of a person that was kind of set in his ways, but with some encouragement, he started to try some new things. And over the course of a couple of years, he wound up trying almost everything. And this is not to say that we're suggesting you do all of these things with every patient or client. Always find what's really most effective for them or what's most interesting to them. But he wound up kind of diving into all of these and really loving each of them. So the ones I just want to make, the ones that I want to make note of, we'll work a little bit backwards from the bottom of the chart, are music. So we used music to improve his attention and motivation during therapy sessions. He was somebody who we would say, pick your playlist, we'll put it on in the background. And he was totally engaged the whole PT session, as opposed to either having no music on or maybe my own playlist that I just kind of had running in the background. He felt like he also had not only was it fun for him to listen to music that he liked, but it gave him some sense of control over the session. He came in, he got to choose the music. He set the tone for the session. We did some dancing and some games, which really impacted his motor planning. And when he saw those improvements, it really helped his mood. He had not had any interest really in group fitness at the beginning. That really took a lot of encouraging. And I did not force him, but I continually, gave him the opportunity. If he wanted to participate, he could. And I slowly would notice that over a few weeks, he would, gaze over, take a peek, watch what everybody's doing. And then eventually I saw him sitting in a chair a couple feet behind everybody else. And then he slowly made his way into the group. And he wound up becoming a really active participant. And it really encouraged him to be more engaged in exercise and encouraged to do so. One of the most interesting things that came out of participation in fitness group was that sitting in the group, he would look around and notice he was having some more trouble with certain motor control activities than others. And he hadn't had that prior. And at first, this kind of triggered some frustration, some depression. But the great thing about it is that he recognized it, brought it to his neuropsychologist, and they were able to really work through it during his counseling sessions, which in the end wound up being a really great benefit. One of the other things is that while participating in fitness group, as I mentioned, there was a small portion of it that was dedicated to adaptive yoga, and he discovered that he really had a lot of interest in it. So he asked if we could start doing some therapeutic yoga during his individual treatment sessions, and he did, and he really, really loved it. He wound up also using some of the techniques we did to carry over to use at home, where he was able to help manage his anxiety. So using some breathing activities or deep stretches to help prior to sleep at night, which helped a lot.
10 minutes.
Okay, thank you. So Alana's now going to speak about the top three. Sorry, we kind of flipped it in the order that's listed.
Okay, so in the interest of time, because I want to make sure we leave time for some questions, I'll invite you to read all the details on this slides, and I'm just going to give some highlights. So specifically for our community outings or reintegration, he was put into that group that I explained earlier, and what we saw was his gait speed was just really fluctuating. He couldn't keep up with the group sometimes, and it really was impacting everybody else. So we put him into a smaller group, and this wound up being a great thing. He was able to then, in a much smaller group, be given more specific goals for just himself and learn new strategies to help promote his independence, which was different than ways he had been doing things earlier, like using a list, asking for assistance, and things like that. It also gave us time to help work on his money management, which he'd previously been independent in, and he was able to gain some independence back. He also participated in canine assisted therapy, and he was one of the people that really all of a sudden would do some things that he didn't want to do otherwise, specifically in physical therapy, but also in occupational therapy. He just perceived less structure on the intervention. It improved his attention, and it just gave him more motivation. We did see some improvements in bilateral integration during these tasks. He did also participate in that community involvement group, and he was somebody, because he loved work, really was able to verbalize and report how much more of a sense of purpose he felt by being able to contribute back to the community. So again, there's more, but in the interest of time, I'm just going to keep going to open it to allow us more time for questions. And so we do have some recommendations for future research. You can read through them. Again, we want to learn more about, are there specific things we can do to help increase cognitive reserve and delay exacerbated cognitive decline? Does structured community integration and a structured program help maintain or improve function in adults with chronic brain injury? We think so, but we know we need more future research that is targeted specifically at this. The other research alludes to similar things. So what are the most effective ways we can help this client population, and to really research more the effectiveness on each treatment area that we touched base upon. There are research to support the use of each of those areas, but many of them are done in different populations and not specifically those aging with a brain injury. Research is so necessary in this area. As we've talked about, this population is growing. More and more people are surviving injuries and living longer and longer and longer. And as technology continues to grow, we think that those numbers will just increase. So we want to learn the best ways now to help those patients in the future as this population continues to grow. There, of course, are multiple barriers associated with research, any types of human research, but we do really want to continue to strive to find out more to specifically help this population. So with that, again, we apologize for rushing through the end, but we do want to leave time for questions.
Okay, we have quite a few questions. I'll start with the first. We encounter many individuals who may be 5 or 10 years post-injury, but never received formal treatment. Can these activities, such as community interaction and socialization, be scaled to benefit someone who has been living with their injury for a long time and lost more functioning as a result?
I think absolutely. So without like specific cases, it's a little bit difficult to answer, but these interventions can be scaled to really anyone that is interested in any of it. It may be done differently. Maybe they're not in a rehab program like you're saying, or maybe they never had initial therapy. So maybe they're just learning some of these strategies for the first time because they've been able to cope with things in the past. At the same time, because we know so much about how socialization and community integration are parts of quality of life and life satisfaction overall, it's never too late to try to start. It just may look a little bit different. But again, there's long as we can physically and safely get somebody in the community or into some of these groups and experience some of these things, I personally, and Jenna can answer as well, don't see a reason why not to try at really any point.
I agree. I think these things can be tailored to a variety of different clients, whether they've received therapy in the past or not. And we can absolutely talk about that more. If someone has any follow-up questions, you're welcome to email us. I don't know if we want to maybe go through some other questions.
We have 5 minutes left. How do these creative strategies for brain injured individuals differ from those for intellectually, developmentally disabled individuals?
So in our experience, Alana and I have all of our focus has been on those with traumatic or acquired brain injuries. But I think in regards to the treatments themselves, they can be applied to either population. The actual therapeutic cues or facilitation that is provided by the therapist may just differ a little bit. And I can't speak from the perspective of somebody who works with those who have a developmental disability. Alana, I don't know if you have any other points to add on that.
No, I mean, it's been a long time since, I was a student that I worked in that population, but I agree. They're not necessarily that different. The specific strategies that we're teaching to perform and engage in those tasks may be different. Depending on the person, but that's true within brain injury themselves, that every person we're teaching their strategies may differ. But I think these interventions, as long as safe, like I said, could be used in that population as well.
Okay, one final question. Is there any particular instrument that may be most beneficial for a person with a brain injury to learn?
I'm sorry, I don't know if the person can instrument as in like an outcome measure tool or an actual like musical instrument. I'm not sure what they're referring to.
It's a particular instrument that may be most beneficial for a person with brain injury to learn.
I think maybe they're asking about a musical instrument, and unfortunately, that's out of our area of expertise. Yes,
Okay.
Somebody commented musical instrument. I, as an OT, not a music therapist, I wouldn't feel comfortable answering that. It's something we could certainly look into if somebody wants to reach out to us.
I agree. I think a music therapist would be better suited to answer that question specifically. But I would also just say that whatever is most interesting to that patient, usually it's found that in rehab, something that is of interest to that person is what's going to be most beneficial to use in treatment. So if somebody has an interest in learning the guitar, but they've never had any interest in learning the piano, I would go with the guitar. That, from a therapist perspective, that would be my best answer. But I agree that a music therapist might have more specific information on that.